Hello, my name is John Clements. We're going to take a few minutes to talk about the human optics iris prosthesis surgery. There's a patient who had a DSEK in that right eye, which unfortunately resulted in a fixed pupil. Patients had really bad glare symptoms and it's been intolerable to them. We're going to try to fix it. This patient has a cataract that developed after the DSEK. So we're going to remove the cataract first, and then we'll place the iris prosthesis. You can see the outline of that DSEK graft there. Cataract surgery for this, relatively straightforward. We used a low flow state here to protect endothelium of the DSEK. Important to have a good sized rhexis here. You don't want it too big, you don't want it too small. If you're going to kind of err on one side, I'd err slightly larger. The iris prosthesis, as you'll see, is quite large. While flexible, you don't want to put it through a real tight, small rhexis. Phacoemulsification in this case proceeded without any difficulties. It's sped up for the sake of time. A stop and chop technique was used. Again, only different here was a low flow settings used, but mainly just helped to protect the DSEK graft that was already in place there. Cortical cleanup is removed, all the cortex is removed. We're going to go ahead, in this case, we're going to place a CTR. Not because of any suspected difficulties with the case, but you want to help to prevent late capsular contraction when the iris prosthesis is in place. It can cause wrinkling and folding of the prosthetic. So an appropriate sized capsular tension ring is inserted. You can see another video in my library for more detailed instructions on how to use the CTR. CTR goes in without any troubles. And here we go, implanting our one-piece acrylic IOL. At this point, we're going to size up the eye. You're measuring on that corneal light reflex, and here I measured between 5 and 5.5 millimeters, kind of from the equator of the bag to the center, and you multiply that by 2. And I decided to use a 10.5 size punch. We'll see that in a moment. After we've removed the viscoelastic from around the IOL, from behind the lens, we put in trypan blue to restain the capsule. That's going to help us ensure that we position the iris prosthesis well. So that's the purpose for this second stain. Refilling with viscoelastic, and now we're putting that viscoelastic on top of the lens. You don't want to put any more viscoelastic behind because you're not going to be able to get it out once the iris prosthesis is in. A third paracentesis is placed. That's going to help us grab it. There's the iris prosthesis. PO comes in that packaging. We've sized it up with that caliper. We know what we want. It's a 10.5 millimeter freehand tree fine. Care is taken here to center this on the pupil. Once that's done, we fold it up and put it through a special injector. You can't use the standard Alcon injectors that we use here at our center. Viscoelastic in that cartridge is going to help you slide that in. If you don't have enough viscoelastic in there, this silicone iris prosthesis is very sticky. It won't load properly. During the insertion, you want to make sure that the pupil is facing upwards in the proper orientation. The graft isn't going to inject kind of upside down. So we're going to inject this as best we can on top of the eye. You see that leading edge going underneath the rhexis. That's why the trypan is important, so you can see that easily. Using a Kugelin hook for this, so 2 Kugelin hooks are important in this case. You can use for manipulation, but as you finalize the injection here, use that hook to help that iris prosthesis come out in the proper orientation. So here we are. A couple of manipulations here to unfurl that. Again, we're keeping it down into the down into the capsular bag. The trypan's helping us to know, like, okay, you can see the far portion there. They see that prosthesis is definitely in the bag. A bimanual approach here with the 2 hooks will help to unfurl. And a big shout out to Dr. Radwa El-Shawari, who's our resident surgeon here, doing a great job. We do this slowly and carefully. This thing it's large, as you can see, and so getting it into the capsular bag, it just requires some patience. some dedicated maneuvers here. We're operating very safely. You see, we've got just over half of that thing is in the bag. And now to get the subincisional portion into the bag, this is why we have that that extra paracentesis that's 180 degrees away from the main wound. That's going to help us use some forceps to grab at the pupil and bring it in. So refilling with a little more viscoelastic here. Again, this eye does have a prior desec, so we're really trying hard to protect that desec graft. Just having some conversation here about how are we going to get this subincisional iris prosthesis in. Here comes the forcep. Forcep is going to grab at the pupil margin here, pull it nasally a bit, and then that Kugeln hook is going to be used to gently move that prosthesis, kind of push it posteriorly and get that behind the anterior capsule. So just kind of walking it around here bit by bit, and there we go. The prosthesis has enough, it's kind of a elasticity there that kind of springs in position once it's in the capsular bag, and that's why sizing is so important. If it is too small, it will move around and the pupil will be decentered. If it's too big, it won't fit well. Do take care that the IOL is centered at the end of the case, because that the prosthesis is rather sticky, and you can decenter your IOL, and the IOL could remain decentered at the end of the case if you're not careful. You see there it's a bit decentered, so we did have to just take a moment to recenter that IOL at the end of the case. Here you see again, you can see the optic edge. And so we did take a moment to recenter that at the end of the case. One thing I'll point out, that the color of the iris prosthesis looks different underneath the microscope than what it does in vivo. And so at this case, it looks like, oh, that's mismatched, like that color is not appropriate. But you'll see actually, with the after photos, that it actually turns out quite well. I've done a couple of these cases, and intraoperatively the color never seems quite right, but it manages to blend really well in vivo. Doing some post-op injections here. I think at that point we'd notice, like, yeah, that IOL is just not well positioned here, so did go back in with some manipulations, try to kind of recenter that IOL. There's some gentle nudging. There we go. Now you see that you don't see that optic edge any longer. That IOL is well centered. And I've got a good result. And so here's that pre-op photo again. Again, this patient was really debilitated with glare and light sensitivity. And here the patient is post-operatively 1 week. She's very happy with the results. Has diminished her light sensitivity, cosmetically much more appealing. This is a great surgery, specifically when you add it on to a phaco to put that iris prosthesis in the capsular bag. The sizing is really important to make sure that pupil is well centered. That's really one of the most key portions of this procedure, is getting that sizing just right. So thank you very much for your attention. Best of luck out there.